Hello, this is Dr. Alkaraguli from Exam Pro. We're going to do a case list defense today, and I'm waiting for a couple more people to join. I logged in a little bit early. Who wants to start tonight with the case list defense? Anybody wants to raise their hand? Can you guys hear me? Let's see, I'm gonna call in Mark. I'm gonna call on Melissa. Melissa, can you hear me?
Yes.
Melissa? Hi. I just
Hi.
wasn't sure if you guys were hearing me or not. How are you?
I'm great. How are you?
Good. Are you a generalist?
Yes.
Okay. Trying to see here if I can pull up your case list. Do you want to be called on today?
Yes, please.
Trying to find your case list here. Do you see it?
I did. The bottom.
Yes. There
There you
you
go.
are. You have a preference which one we open? Which one we go over?
I don't know. Let's. No, I don't. Whatever
Let's do.
strikes your fancy. There, you have your cursor on office. Looks great.
Okay. Okay, so let's start with case number 1. You have annual women exam. Can you tell me, please, in this age group, age 49, what tests do you order? What is the test you order in that age group for an annual exam?
So, a couple of things within for a 49-year-old. I verify if they've had a mammogram within the last year. This patient had not yet had a colonoscopy yet, so I referred her for that. She for depending on the patient, pap smear if indicated. I'm also looking at as far as if they have a primary care provider or not, and if they have screened the patient as far as thyroid, glucose, cholesterol screening. I'm asking her as far as if she's up to date with vaccines. So in that age group, when her last tetanus booster was, if she's had COVID or flu. Those are some of the things I'm looking for initially.
Okay, so I asked you about tests. I haven't gotten to the question about vaccines yet.
Oh, yes.
But in terms of tests, can you repeat again? I know you said a couple. You said the mammogram. What else did you say?
Mammogram. I don't do an actual colonoscopy, of course, so I do send a referral for that. Pap smear if indicated. Thyroid, glucose, cholesterol testing.
When do you do those? What age do you start those tests, the thyroid and the glucose and the cholesterol?
Dependent upon their risk factors as far as in general, many of those tests are started by about like age 30 or so, but it's dependent on any additional risk factors such as family history of diabetes, symptoms, or like gestational diabetes in previous pregnancy. for somebody generally in their 40s, they're usually having screening done about like every 3 years or so if they don't have any of those conditions, but that's based off of that's just based off like screening alone.
Okay. What about immunizations? What immunizations do you offer for that age group from like 40 to 64?
Um, so for that age group, I'm asking and verifying as far as annual flu vaccine, if it's annual flu vaccine, COVID vaccine, or booster, if they're up to date on a Tdap. After age, I believe it's 60, I'm asking about shingles, but
Okay.
not in this patient.
Okay. What if you had somebody who came in for an annual visit at age 13 to 18? Then what tests would you do? Or what tests would you order at that age, 13 to 18?
13 to 18, I'm not typically ordering anything as far as preventative screening unless they report to me that they are sexually active, in which case I would do gonorrhea, chlamydia swabs, but no other actual testing that I'm doing at that point.
What immunizations would you recommend for that age group, 13 to 18?
So I talk to my patients about the HPV vaccine in that age group. I can also verify with them as far as if they have received a COVID vaccine, a flu vaccine, and if they've been up to date with their other pediatric vaccines, like within the teenage age group, I could ask them if they've had like the meningitis vaccine done.
Okay. Let's talk about the other age group that we skipped, age 19 to 39. What tests would you order for that age group, 19 to 39, for an annual exam?
19 to 39. So pap smear when indicated, gonorrhea and chlamydia testing, specifically for all those between 19 to 25, and then also additionally for those in the 25 to 40, depending on any additional risk factors that they have, such as like multiple sexual partners. Then I'm also at that point considering screening as far as diabetes, thyroid, cholesterol.
Okay, what about immunizations? What immunizations for that age group?
19 to 39, I'm looking at annual flu, COVID and booster, verifying if Tdap booster is up to date. Nothing else specific. Also HPV vaccine as well, if they have not yet already received, if they've not already received that course.
Okay, sounds good. What about if you have somebody above age 65? Then what tests would you order and what immunizations would you recommend?
So for testing, I am looking at mammogram. I'm still completing annually if under age 75. I'm looking at when their last colonoscopy was and ordering if indicated. I'm talking with them about ordering a DEXA scan. Pap smear only if indicated, such as like a previous history of abnormals. And then additionally, as far as testing, if their glucose, thyroid, cholesterol has not been verified or updated with their primary care physician, then I'm adding those. In
Okay, so
regard, can you repeat the initial question, please?
no, that's fine. The reason why I did that is that in your case list, in anybody's case list on their annual exam in the office, they can do exactly what I just did. They'll see, okay, age 49, and then they'll leave everything in your case list, and then they'll ask you. A lot of them will, depends on what you have on your case list. So if your case list has no complications and it's a normal good case list, they were gonna ask you general questions. If there are stuff in the case list that they want to know why you did this or why you did that, they probably will start with that and then go from there. And so I just looked at the first case in your case list, and I saw annual exam, and I skimmed it real fast, and there's nothing really special except for that skin lesion with the skin biopsy. Did it come back showing anything malignant?
Actually, the patient didn't come back to have it done yet. And
Oh,
as in yet, this was, oh gosh, like
so
a
you
few
didn't,
months.
you said skin biopsy pending, so that means that it was done, but you're pending result, or pending meaning you're gonna do it.
No, she's scheduled to have it done, and that's why I wrote pending.
But you're not the one doing it, right? The dermatologist is doing it, or who's doing
No,
it?
she's scheduled with me to do it.
So what were you gonna do? Were you gonna do a punch biopsy?
This was a with this, it was I was just going to do a actually it wasn't even that. Let me think. No, I was just going to do like a simple excision. It's slightly raised, less than a centimeter. Um,
What were you concerned for? Are you concerned melanoma, like malignancy? What were you thinking?
I was not concerned for melanoma. Did not have any characteristics as far as malignancy is concerned. The patient was concerned. She has had a history of a couple of skin tags before and requested removal and just wanted it removed.
So do you normally do those kind of things, or do you normally refer them to a dermatologist? Because that doesn't really fall under our specialty.
If I have concerns as far as any sort of malignancy is concerned, then I certainly refer them out. If it appears quite simple, then I feel fairly comfortable as far as my skills, as far as like um, from a surgical experience to do a simple excision of something in the office and refer if needed.
Okay, that's fine. So I'm gonna stop here and I'm gonna go over all the questions that I asked you and answer them. Okay, just so you know why I ask those questions. Very easy question on any office case list. The first thing that they would probably look at, because the annual exam is always the first one. If that's what they have in mind that they're going to ask you, they'll ask you, you wrote here that you did, this is an annual exam. What other tests did you order? What age do they start those tests, like the blood test? How often do they do them? And all that stuff. So I asked you, what tests should you order in an annual visit for age 13 to 18? So at that age, like you said, you're just going to do GC, chlamydia, if they're sexually active, HIV, if they're worried about, acquiring it from their partner, and you don't have to even do a pelvic exam. You can just do it through the urine. As for immunizations for that age group, I would do influenza, Tdap, DT, MMR, varicella, hepatitis B, HPV, and meningococcal. And for all of those age groups, almost all of them, the influenza, Tdap, TD, MMR, varicella, go for all of them, because you offer them for all those patients. If they haven't taken them, they will take them. And then the ones that are specific for this age group would be hepatitis B, HPV, and meningococcal, and of course, the COVID vaccine. would be
Okay.
something that you offer if they've never had it before. And then for age 19 to 39, the tests that you would order would be Pap smear, obviously starting at age 21, gonorrhea, chlamydia, or HIV if they're sexually active. And as for immunizations in that age group for 19 to 39, that will be the same: influenza, Tdap, DT, MMR, varicella if they're non-immune, and then HPV. Okay, and then for the other age group, age 40 to age 64, the tests would be Pap smear, colorectal cancer screening. At what age do you start the colorectal cancer screening?
45.
Okay, and then the mammogram at what age?
With no other risk factors, 40.
Okay, and then we talked about the blood work. So you're gonna send diabetes testing, lipids, and TSH. The diabetes testing at 35 every 3 years, lipid as well at age 35 every 5 years, unless those patients have risk factors or very strong family history of diabetes or hyperlipidemia or hypertriglyceridemia, then you would test them earlier. You would test them at age 21. But if they don't have any history, any risk factors or anything, then you would start at age 35 when they come to you. And if they usually, young women have their OBGYN, either their OBGYN or their primary care provider. They normally don't go to both if they're healthy. So if you're the one that they're coming to, then you're their primary care provider, then you should initiate those tests for them until they, something happens and then they go to a primary care provider. So the glucose testing and the lipids at age 35, the glucose every 3 years, lipids every 5 years. If they have risk factors, you start at age 21. TSH starting at age 35 every 5 years. And then you would also I'm sorry, before they used to recommend starting aspirin at age 55. For now, I don't think that's still a recommendation. As for immunizations for this age group, 40 to 64, immunizations would be influenza, Tdap, TD, MMR, varicella, the same ones that I talked about in the previous age groups, plus herpes. And then you can still do HPV up to age 45, right? Because this is the age group 40 to 64. And then for annual exam for women over age 65, the same ones that we just talked about, the mammogram, the colorectal cancer, testing for diabetes, lipids, and TSH, plus you would add a urine analysis annually, and of course the DEXA scan. And the Pap smears, do you still do them above age 65?
Only if they've have an indication as far as a previous abnormal within the last, they had a history of HSIL within the last 20 years that they have follow-up for.
Okay.
But if they've had 0 abnormals, then I do not do them after 65.
Okay. As for immunizations for this age group above age 65, same ones that I mentioned. Those are easy. I mentioned them in each age group because you always ask the patients about them. Influenza, Tdap, DT, MMR, varicella, and then you're going to add to it zoster and pneumococcal vaccine. And of course, for all of those age groups, you would always also ask about COVID. Okay. I think I'm going to call on somebody else.
Thank you.
Of course, yes. Okay, let's see. I have Macy Burton. Let me unmute you. Hello. Did I say your
Hi.
name correctly?
It's close enough. It's Maisha. That's okay.
Okay, I'm sorry.
That's okay.
Okay, so let me pull up your case list. How are you?
I'm doing well. How are you?
Good. Are you a generalist?
I am.
Where do you practice?
I'm in Arizona.
Okay, nice. Okay, so which case list do you want me to go over with you?
I'd
Would you
like
to
to
do
do
again, or do you want to do OB or GYN? What do you want to do?
Can I do OB? I haven't done OB yet.
Yeah, you can do
Thank
OB.
you.
Okay, let me see what I'm going to ask you about. Okay. Is there a topic or a case in specific that you're worried about?
No, I don't
No.
think so. No, because I had a chance to kind of talk through some of them, just like the verbiage when you kind of come on and you're continuing the management that was already dictated by a partner. But no, I don't think there's anything that falls too outside of the lines.
I'm just flipping through it. So I don't see anything that stands out. So usually the first thing those examiners do the night before the exam, when they get all those assignments and they get those case lists, I think they get them the night before. And obviously they're not going to read every case list because they have so many of them. There's more than one person doing the exam. They're just going to do what I'm doing now. They're going to flip through it, look and see if there's anything that stands out. Like this one, see this, she has DK. You did DKA, that's interesting. They can ask you about this. See, and then they're just gonna look at stuff like that. And then if they don't see anything like that stands out, then they're just gonna go, okay, so she has diabetes, she has IUD, she has hypertension. We'll ask her about any of those general questions. And
may I do, now that you mention it, there's one pretermer, I think she's like 29 weeks.
Case.
She would fall under the preterm delivery section, I believe is where I put her.
Is it all the way up?
Actually go a little bit down. I thought I saw it pass by. Shucks, I'm sorry, I should have looked for it.
Oh.
No.
Did you have anything that you were worried they were gonna ask you about it?
No, I just feel like that's a case where you can talk about a lot of things. Like
you don't want to talk about DK?
So I would say yes, but I did that case previously with a mock oral.
Okay.
And that's the only reason.
You started doing your mocks?
I have. I'm in October, so.
How have they been going?
They've been going well. It's kind of that like learning to say less, I think, is starting to be my approach, so that they can ask you questions and you can kind of share what you know in that regard, but not, oh, there she is. Yeah, but not, you know, talking too much and now you're in to like the higher level questions that you may not know the answers to.
Okay, so I'm looking at this case. I'm gonna ask you, now that you have this case, it seems like you did everything right. I'm looking at the management, but I'm gonna ask you then about preterm labor, okay?
Okay.
So tell me some risk factors for preterm labor.
Advanced maternal age, history of preterm labor, gestational pregnancies, short interval pregnancies, if you've got an infection, things like that would be the first ones I think of.
Steroids. What is the benefits of use of steroids and MAG in managing preterm labor and PPROM? What are the benefits?
Sure. So in terms of magnesium, current recommendations are to use magnesium for neuroprotection of the preterm infant. Historically, and there is evidence that does show that it can be used as a tocolytic. However, that's not the primary function of it. It's more considered of a side effect at this point. And so in terms of intracranial hemorrhage, in terms of the betamethasone, that is useful with assisting with fetal lung maturity, protecting from intracranial hemorrhage, as well as intestinal issues like neck.
What about nifedipine? Why'd you give her nifedipine?
So that was in hopes of, as a tocolytic, in hopes of getting her through her steroid window, or the 48 hours of steroids.
What dose do you give? What is the mechanism of action of nifedipine?
The dose that I give for nifedipine is a loading dose, usually of about 20. And then after that, I believe it's, what do we do? 10Q6, I believe. And then in terms of mechanism of action, it helps with vasodilation, like peripherally. And so that can also assist with, like as a tocolytic in terms of the calcium channels and contractions from that standpoint.
When is nifedipine contraindicated?
Let's see. Well, if the patient had some kind of an allergy to nifedipine, that would be a contraindication. Let's see, if they had a low blood pressure, because it's also going to affect that.
Okay. What other tocolytics are there other than nifedipine that you would consider giving?
Did you, oh, sorry, you broke up. Did you say tocolytics?
Correct. What other tocolytics would you give?
Okay, you can give terbutaline, that's a tocolytic, but that's going to be a bit shorter acting. Some people do choose to use, oh my gosh, indocin, and that can also vary in terms of your gestational age, because there can be contraindications past the 32-week mark in terms of cardiac issues for the newborn.
Are you saying the contraindications for indomethacin are age being above 32 and cardiac, you said?
That's my understanding, yes.
Okay. I didn't ask you about contraindications for endometrial.
You did not.
Okay. So what are some other side effects of giving endometrial if you gave it above 32 weeks?
The biggest I know is the premature closure of your patent ductus arteriosus. That is the one that I believe it to be the most significant.
Okay.
Like before your 32-week mark.
What are some contraindications to using tocolytics in general?
So if you think that the patient is abrupting, that would be a contraindication. If you believe there is an intrauterine infection, geez, sorry, I have a very big dog and he's knocking stuff over. Let's see, those would be the two that I would mention straight away.
Okay. Was there, with this patient, do you know what her dilation was?
Yes, so she had been initially checked in an outside hospital, found to be 1 centimeter. At presentation to us after transport was 3 centimeters.
Okay. Let's say you have somebody who comes in, is getting an ultrasound, and you find an incidental finding of a short cervix. With like this patient, the prime, no history of preterm labors. And she's not complaining of anything. She just has an incidental finding of a short cervix on ultrasound. Well, first of all, tell me, what is the definition of short cervix and how would you manage this patient?
Can I ask her gestational age?
This one, 29 weeks and 2 days.
At 29, okay. So at this point, if you have an incidental finding, you're more so concerned with patients who are in that like really less than 2 centimeter range. At 29 weeks, it really is more of a matter of observation, because it's a matter of observation at that point. In our practice, we do not continue serial cervical links, even with an incidental finding. You can discuss potentially like a vaginal progesterone, but otherwise it's really just watching, and then having, in our practice, we would do actually growth ultrasounds.
Okay, so what if she's not 29? Let's say she did it at her anatomy scan. Let's say she did 18 weeks and you find that finding. Is that going to change anything from what you just said?
It could. So given that age, you can do a rescue cerclage. In our practice, that's done by our MFM. And then you would continue, or you could continue again with your vaginal progesterone.
You would do a cerclage?
Pardon?
You would offer her a cerclage if she doesn't have any history of preterm deliveries?
So in our practice, we would, but generally speaking, you could have like your history indicated cerclages or your like exam indicated cerclages, or you could just continue to monitor her up until the 24-week point and see how she does.
So what if you have somebody, forget about this case, what if you have somebody who is, let's say 20 weeks getting her anatomy ultrasound, and she does have a prior history of preterm labor and delivery? How would you manage her?
Sorry, you said she's got a short cervix or no?
Yeah, we're still talking about the short cervix, correct?
Okay. And she's got a history. So in that particular case, yes, it would be more of a recommendation to continue with a cerclage, or to offer the patient a cerclage in that setting, since she does have a history.
Anything else you would offer her other than the cerclage?
Like continued monitoring, same with vaginal progesterone.
Okay. What if she was twins?
Sure. So historically, and I believe ACOG kind of hedges in the middle. So we generally do not perform cerclages in twins. However, like more research is kind of starting to come out that's saying it's not as contraindicated as we previously thought. So it's something that could be considered with proper counseling of the patient.
Okay. Okay, what antibiotics would you give this patient? You wrote your IV antibiotics. What antibiotics would you give?
Sure. In this particular case, we initially started with IV ampicillin because we, for GBS prophylaxis in the preterm setting. She was intact.
Okay. And you mentioned vaginal progesterone. There's also 17 hydroxyprogesterone, the intramuscular injections. Do you ever give any of your patients those?
So historically, yes, like more so during residency, but in the recent years, we have transitioned to PV progesterone in lieu of IM Makina.
Okay. Okay. I'm going to go over some of the stuff that I just asked you.
Mm-hmm.
How did you feel answering those questions?
I don't like it. I mean, it's oral boards, but it's, I don't know, like I said, I'm trying to say less than, I'm just trying to answer your question, I think is the best way. So it's mostly learning how to approach the questions as opposed to having to like really study. Mm-hmm.
Are supposed to be straightforward and fair in the oral board exam. They don't want you to fail, they want you to pass. But sometimes when people start talking and going into other topics, the examiner, they can't help themselves. They're going to ask you more questions about whatever you talked about.
Mm-hmm.
So I was going to ask you side effects of endometrium because I was going in that direction. But you talked about it without me even asking. And maybe that examiner who's examining you didn't want to go there, but then
Mm-hmm.
you volunteered that information, and then you said something in the contraindication that wasn't correct. And now you put yourself into like they're gonna start asking you more to see what else you're gonna say. And so always in the exam, everybody says that's the advice that I give to everybody, and everybody gave me when I was doing the exam, was that treat the exam as a deposition. Do
Mm-hmm.
not say more than the question, even though you know a lot more. Obviously, we all know more. But just for the sake of the exam, they ask you one question, answer the question, and stop. And wait, pause for the next question. Sometimes if you have something that you're really good at and you want to talk about it, you can say it's like, oh, by the way, like say something, and then they will say, oh, you talked about this, let's talk about this. If you can do that and direct the examiner to talk about something that you want to talk about, that you feel very good about talking about, then that's great. You know what I mean? Like you can say,
Yes.
You can add something to the conversation, but not say it all. Say part of it and have them ask you more. And that way you'll talk more about something that you've studied really well.
Okay.
Okay, so I like to ask about risk factors. I ask that a lot, but I don't take more than 1 minute about talking about it. Just because I go on the practice bulletins and I see all of them have risk factors. So I just ask about it every time. So preterm labor and delivery. Yesterday, I was also doing another webinar, and I was telling everybody that when they ask you about risk factors, the same condition is
Mm-hmm.
prior to labor and delivery is also a risk factor. And then in OB, it's pretty easy to guess, even if you don't remember anything. So short cervix, history of surgery on the cervix, vaginal bleeding, untreated asymptomatic infection, also low maternal pre-pregnancy weight, smoking, substance abuse, all of those are risk factors. The next question I asked you were the benefits of use of steroids and MAG in patients. So steroids decrease neonatal morbidity and mortality. They decrease respiratory distress syndrome. They decrease intraventricular hemorrhage, and they decrease necrotizing colitis. And the MAG is used for fetal neuroprotection. It decreases the risk and severity of cerebral palsy. What is the dose for giving the MAG for fetal neuroprotection?
So we do a loading dose of 4 grams and then a continuous of 2.
Okay. And then how long do you do it for?
So currently at my institution, we do it for 12 hours. Historically, like in training, we would do it for the full 48 hours if we could get the patient through their window.
Okay. And then I asked you about nifedipine, and I asked you about contraindications. And the contraindications are cardiac disease, patients who have hypotension, and also caution with people with renal disease. And then after that, we talked about nifedipine, and the contraindications would be above age 32 weeks, and not in cardiac patients. You said cardiac. Cardiac is with nifedipine. And indomethacin is patient with hepatic or renal disease.
I meant baby for the, are you talking about the endomethacin?
Yes, I was talking about, for the mom contraindications, but then I asked you fetal side effects afterwards.
Okay, I apologize. I just didn't answer your question correctly.
Yeah, you misunderstood me. That's fine. Fetal side effects would be what you said: closure of PDA, pulmonary hypertension. Those patients also have oligo, hyperbilirubinemia, intraventricular hemorrhage, necrotizing colitis, all that stuff.
Okay.
Then I asked you contraindications to tocolytics, and you said abruption, but also severe IUGR, severe preeclampsia, IUD, fetal anomalies that are incompatible with life, if mom is bleeding and is unstable. And then we talked about preterm labor and delivery in terms of somebody who's a singleton with no history of preterm labor and delivery. So I don't think cerclage is recommended if she doesn't have history of preterm labor and delivery. If she doesn't have history of preterm labor and delivery, you would just do vaginal progesterone. And the cerclage, you said in your institution you would do it, but for the sake of the exam, I would just say what ACOG says in the practice bulletin, so that they don't start asking you more questions and putting you on the spot. Just say what's recommended in the exam, so they don't keep asking more questions about it. If she has prior preterm delivery, then the cerclage would be indicated. Okay. What else did we talk about? I think that's all that we covered, right?
Yes.
Okay. I think you did good.
Thanks. Thank you.
And whoever did the before you, I forgot her name, Vershio, Melissa also did good too. Okay. Does anybody else? I'm gonna give a chance for somebody else to do this. Thank you so much.
Thank you.
Who else wants to raise their hand and get asked on their case list? Okay, I'm looking here. I see Daniela, I see Aaron, and I see Serene. I'm gonna go with Daniela first, and then I'll go to you guys after. Let me see if I can unmute her. Unmute. Hi.
Hello. Hi.
How are you?
I'm good. How are you?
Good. Have we talked before? Did I call on you before?
I think I talked to you yesterday or the day before.
Yesterday. Yes. Okay. Okay. So what cases do you want to go over?
I'm honestly okay with anything at this point.
Okay. Do you want to do GYN since we already did a little bit of open office?
Yeah, that sounds good.
Okay. Do you have any case that you are worried about? I'm looking at your case list.
Trying to look too. I mean, I have a weird one, but I already practiced it.
Okay, then let's talk about something else if you already practiced it.
Yeah.
Let's talk about, let's see here. We have a lot of postmenopausal bleeding. Did anybody do postmenopausal bleeding with you?
No, I haven't done that one.
Let's do that because that's a very
Okay.
important topic in GYN and in
Mhm.
office. So tell me, how would you manage a patient who comes to your office with postmenopausal bleeding? What would your first test would be? How would you work her up?
So typically in our practice, if I'm seeing someone for postmenopausal bleeding, they usually get referred to me. So at that point in time, oftentimes they've already had an ultrasound, so I don't repeat an ultrasound if they already had it. But
So
myself,
don't tell me if somebody's referred. Patient who comes to you for the first time,
okay.
has not seen anybody before. You're the first
Mhm.
person she.
So I start with my history and physical exam, and um, from that point, determine if there's any risk factors. First thing that I typically go for, if feasible, is I tried to do an endometrial biopsy in the office.
Okay, so you're going to start with a biopsy.
Yes, after
Correct?
my history and physical exam.
Okay. So the biopsy comes back negative. What's next?
So if my biopsy, did it come back negative or did it come back normal or benign?
Right, normal or benign.
Okay. So if it came back normal or benign and the patient's bleeding stops, then I stop there.
Okay. Let's say she goes home and then she comes back again in like another for 3 months and she says she's spotting some more.
At that point, I typically will give the patient the option to proceed with either doing a transvaginal ultrasound to look at the endometrial stripe, the thickness of the stripe, versus we can go and proceed with a hysteroscopy DNC to evaluate the whole uterine cavity.
Okay. And so let's say you did a hysteroscopy DNC.
Mhm.
And the hysteroscopy DNC didn't show anything. How would you manage the patient afterwards?
I would
You're gonna
reassure
send.
the patient.
Yeah,
I'm sorry.
sorry, go ahead.
I was just going to say, I would reassure the patient, given the fact that we've had a negative biopsy and hysteroscopy DNC did not demonstrate any evidence of anything concerning for precancer or cancer, and continue follow up with her in regards to her symptoms.
So let's say this patient comes back for her annual exam the next year. You're talking to her and she tells you, by the way, I'm still spotting. Are you gonna work her up again, or are you just gonna reassure her and tell her everything's okay?
If I hadn't already gotten an ultrasound, I would get an ultrasound at that time.
Well, you already worked her up. You did the ultrasound, she came back bleeding. You did the biopsy, came back benign. She bleeded again. You did the hysteroscopy. Hysteroscopy didn't show anything, but now she's coming back a year after with the same symptoms. What are you gonna do?
Then she would theoretically need the workup again.
So are you gonna do it every year if she comes back bleeding, or just the first year and then tell her you're okay and not do it again?
If she has persistent bleeding, then at that point, it could be continually that she's having issues with like atrophy and things like that, but she shouldn't have continued bleeding. At some point it should stop. So I would talk to her about either continuing to watch and wait, knowing that we've had a negative workup, or she can also opt for a definitive management, but that's what I would talk
What
to her
would
about.
definitive management be?
If she has persistent bleeding, she could also, consider, if she's postmenopausal, she could consider undergoing a hysterectomy
For the spotting?
if it's bothersome to her.
Okay. Let's say you have a patient who came to you from the ED, referred to you with an ultrasound that showed a thickened endometrial lining, and let's say she's like 60 years old, and she went to the ED because she had some abdominal pain. They did the ultrasound and they found this finding that she had a thickened endometrial lining. How do you manage her?
So she would need an endometrial biopsy.
Even though she's not bleeding?
I thought, I'm sorry, I think I misunderstood you. I thought she was bleeding
No, I said this patient came to you with an ultrasound in her
for
hand. She went,
abdominal pain.
yeah, for abdominal pain. Then they did the ultrasound. The ER doctor saw a note on the ultrasound that says the lining is thickened. They didn't know what to do with it, so they sent her to you to follow up with her. So she's not bleeding, but let's say her endometrium is like 8 millimeters.
If it's 8 millimeters, I would not do an endometrial biopsy, but if it was thicker, say about a centimeter, then I would recommend an endometrial biopsy.
Okay, so I'm gonna stop here.
Okay.
How do you feel about postmenopausal bleeding?
I mean, I think we all feel weird whenever we're doing any of these practices, but
Okay, so I asked you the same questions I was asked. I did the exam back in 2015, so it's been a while, but I can clearly
okay.
remember all the awkward questions that they asked me. And that question about what are you gonna do if if everything is negative and she comes back a year after on her annual, and are you gonna
Mhm.
do the work again, and are you gonna keep doing it every year? Those questions, they're not written in the practice bulletin. They're basically just, it seems like when you answer everything correctly, they're going to reach to this point where they want to see what kind of provider are you, what are you going to do,
Mhm.
how are you going to manage this patient. I feel like at that point I felt very uncomfortable because I kept saying I would repeat it every year, just because I'm that kind of person who would always be worried that what if this year she developed cancer, and
Right.
told her it's okay, and we already did the full workup, and don't worry about it, here, take some vaginal cream or something and you're fine, and then she comes back and she has cancer. So I'm that kind of person who would probably do that workup every year if
I
she
probably would
continues
too.
that. It's probably not, I don't know if that's what is recommended by ACOG, because they don't really mention that, but cancer can happen anytime, and just because she had a negative workup last year doesn't necessarily mean that she doesn't have it now. So when I said that to the examiner, she gave me kind of a look, which they're not supposed to do. Like she's saying to me, really? Which kind of made me very uncomfortable in the exam. But they'll do that to you in the exam. But just, I passed with flying colors. I did really good in the exam. But there were some moments with this that felt to me awkward. Like, if you feel uncomfortable when people are asking you this. But everything else that you talked about is good. In the end, there's a committee opinion about postmenopausal bleeding where they say you can start with either the ultrasound or the biopsy. You don't necessarily need to do them together. I personally do both when I see patients in my office, and you can say that in the exam. You can say the committee opinion says we don't have to do both, but I do both. If that's something that you do, you don't have to say that. Only if you do that. And then, they go through that scenario where, well, why would you do a hysteroscopy DNC if you already did an ultrasound and a biopsy is negative? That could be one of the questions. So why would you do that?
So in that situation, if I had persistent bleeding, I would do it because the endometrial biopsy really only samples about 15% of the uterine cavity. So there is that possibility of still missing something.
Right. That is absolutely correct. There's also, even if the lining is thin and the patient continues to bleed, endometrial cancer type 2 can happen with thin lining. And so there is still a chance that it's rare, it's not common, right? But it's still a chance that the lining might be thin. You might have missed it with the biopsy because the lining is thin, and she could have cancer in there. So the right answer is, even after a negative ultrasound and a negative biopsy, if the patient comes back to you again and says that she's still bleeding, you have to offer her a hysteroscopy DNC. And if she comes back in her next annual and she's still bleeding, I believe you should do it again, because you never know what's going on in there. What happened in a year, you don't know. And then as for the question that I asked you, that is also part of the committee opinion on postmenopausal bleeding, about if you find an incidental finding of a thickened endometrium, are you gonna do a biopsy or not? So the committee opinion says you don't have to do a biopsy unless she has risk factors. So if she has risk factors, you're gonna do the biopsy, even if the thickening is not very impressive to you. It's not more than 10 millimeter. You would do it if she has risk factors, if she's obese, if you know any of the risk factors for endometrial cancer, you would do an endometrial biopsy for that patient. Now, in the practice bulletin, not the practice bulletin, sorry, the committee opinion, they don't say that if it's more than 10 millimeters, then you would do it. That I think that is in up to date.
It isn't up to date, and that's where I've seen it, because it's not in the committee opinion.
It's not, but you can still say that. I mean, committee opinion and practice bulletins are what we go back to. But I mean, you can say, I would feel uncomfortable not doing a biopsy on this. I think in my practice, if a patient has a thickened lining more than 10, I would offer her an endometrial biopsy. Because that I would feel more comfortable, because she could be you know, having cancer that is undetected, and she's probably going to come back later on bleeding. Also, a lot of our patients do have risk factors for endometrial cancer. A lot of them are obese. And so if you think about it, you really should do a biopsy. Okay. Last thing, and I'm going to let you go. I'm going to call on somebody else so I can give room to more people to do this. Give me some indications of doing endometrial biopsy in general.
So anybody who comes in with abnormal uterine bleeding and is over the age of 45, or anybody under the age of 45 who would have risk factors or have failed medical management, then you should do an endometrial biopsy.
Okay. Anybody else?
There are some hereditary cancer syndromes too, where they actually recommend screening with endometrial biopsy. I believe it's Lynch syndrome after the age of 35.
Okay, sounds good. Thank you so much for participating.
Thank you.
Okay, I'm gonna take one more or two more people, I think, depending on how much time we have left. Okay. Who else wants to? Okay, I'm gonna call on Serene. Okay, you Serene. Hi, Serene.
Hi, how are you?
Good. Did you wanna do which case
You
list do you want?
You can pick one. Just until you open up my case list, I do have a question that I wanted to clarify. I wrote it in the little chat, but if a postmenopausal woman comes in with like an incidental outside ultrasound showing thickened endometrial stripe, but she has no bleeding, you would sample her if she had risk factors?
Yes, that's what the committee opinion says. If you go back and read it.
Okay.
Okay. Okay. Let's do, you want to do office again?
Sure.
I am going to divide whatever time left between you and Aaron, because you are he was the other person who was also raising his hand, and I wanted to give everybody a chance to talk a little bit. So,
okay.
Let's see. What do you have? Family planning. Let's talk about contraception a little bit. Did anybody ask you questions about contraception?
No.
Okay. Where is it? You have your etonorgesterol implant placement. Tell me how you counsel patients about the implant placement.
Okay, so I counsel patients, I explain to them that this is a long-acting reversible contraception. I discuss with them that of all the contraception options, it is the one that is the most efficacious at preventing against pregnancy. I discuss with them that it is for 3 years. However, if they want to remove it prior to then for whatever reason, they don't like it or they want to get pregnant, we can remove it earlier than that. I discussed with them the bleeding pattern on nexplanon, and I explained that it can be a little bit unpredictable and that some patients do have regular cycles, some may have irregular spotting, some may have irregular bleeding with it. I discussed with them some side effects that do include those irregular bleeding or spotting, maybe amenorrhea, other side effects such as maybe breast tenderness or mood changes. And then, yeah.
Okay. And so what is the success rate for the implant?
In terms of like the efficacy against pregnancy?
Yes.
Its pregnancy failure rate is 0.05%.
Okay.
Like the chance of
And
being pregnant.
what is the percentage of patients in your practice that come and want the implant removed because of irregular bleeding or the side effects?
I would say personally, I would go with about 15 to 20% actually.
Okay. And what is the dose in it?
68 milligrams of etonorgesterol.
Correct. And what is the mechanism of action? How does it work?
It helps to prevent ovulation. Probably something else that I can't remember right now.
Okay. So mechanism of action, it affects the hypothalamic pituitary ovarian axis, it thickens cervical mucus, it makes the endometrium hostile to implantation. And you're right about the dose, it is 68 milligrams.
Okay.
Okay. And so let's talk about contraindications of using the implant. Who you wouldn't recommend it to?
I wouldn't recommend it in someone, for example, who maybe had a history of it migrating, I guess. Someone who wouldn't be a candidate for hormones in general.
So anybody who has a current or past history of DVT, people who have hepatic tumors or active liver disease, undiagnosed abnormal genital bleeding, personal history of breast cancer or known or suspected breast cancer, or any hypersensitivity to any of the components.
Okay.
Right? Okay.
Yes.
Okay. Let's talk a little bit about the IUD.
So different when you're like being asked them, you like forget everything.
Of course, that's the whole purpose of this. We're all physicians, everybody knows what they're doing, and this exam is just ridiculous. That they put you on the spot and you have to remember everything. You know everything, you just have to remember it and say it, and that's the difficulty of the exam.
Yeah.
Okay, let's talk about IUDs. What are some side effects of, not side effects, sorry. What are some benefits of using the IUD?
So benefits are obviously pregnancy prevention. It can help women with heavy bleeding, so dysmenorrhea, as well as abnormal uterine bleeding. It can help improve anemia, for example, from that. Other benefits would be it helps some women with endometrial hyperplasia, and that's all I can remember now.
Okay, so benefits of Mirena: it decreases blood flow with amenorrhea 20 to 80%. It treats endometrial hyperplasia, treats endometriosis, fibroids, and adenomyosis. And the benefits of the copper IUD are for emergency contraception. What are some contraindications to using the IUDs?
The same that you mentioned for the implant.
Yeah, except there's a little bit more. So like if the cavity is distorted, You know, if there's an ongoing infection, then you wouldn't put the IUD in until she's treated. Um, and the other stuff that I mentioned, like if she has history of breast cancer or liver disease, and also on the copper IUD, if she has Wilson's disease or copper allergy, then you won't put the IUD in her.
Right.
Okay, I'm sorry. It's the end of the webinar. I want to call on Aaron because he raised his hands. Aaron, do you still want to go? I can give you like 5-7 minutes. I don't see your hands raised anymore. Do you still want to go? Okay. Okay, thank you. I'll call on you more next time.
Okay.
We did talk yesterday, didn't we?
Yes, we did.
Okay.
Okay,
So I don't feel bad.
No, don't feel bad. Thank you.
Okay. Hi, Aaron.
Hi, how are you?
How are you?
Good.
Sorry, it's the end of the webinar, but you were the last person who had his hand raised, so I wanted to give you a chance. Which case list do you want to do?
Any of them?
Okay. Any of them? Which one? Oh, cervical cancer. Are you an oncologist?
I'm in my fellowship. Yes.
Oh, okay, cool. So they probably won't ask you that right at the beginning. You have a lot of cancer stuff. Ooh.
Yes.
Maybe I shouldn't ask you GYN. Let's go back. Let me ask you office since this is your strong suit. Let's go back. Okay.
I wouldn't call any of them my strong suit. But sure.
No? Okay.
Office.
Okay. Let's talk about how much time do we have? Okay. Let's talk about those topics. The chronic pelvic pain will take us like at least 15 minutes. Let's talk about, we want to talk about BRCA, or maybe we can talk about, still thinking, I'm looking at stuff. Okay. Let's talk about menopause.
Okay.
Tell me, this patient has lichen and she has menopausal symptoms. Well, first of all, tell me, how do you counsel patients with menopausal symptoms?
So I would assess sort of the symptoms that they're experiencing and their age and counsel that this is a normal physiologic process, typically around the age of 51 in the United States, at which point estrogen levels fall as ovarian reserve decreases, and typically the main symptoms that people experience are vaginal dryness and irritation, as well as hot flashes.
I'm gonna stop it. I told you, how do you counsel her? You're telling me all the symptoms. The exam is short. It's only half an hour. I know it seems like an eternity for us, but you have to just be to the point. So when you're counseling this patient about hormone replacement therapy, what do you tell her about the hormones?
So I would tell her, based on her symptoms, there's options for observation and conservative management, medical management in the form of vaginal creams, and hormonal replacement therapy in the form of oral and transdermal medications. There are other non-hormonal medications that are also options for menopausal symptoms, including hot flashes.
Okay. Tell me some contraindications to giving hormone replacement therapy.
Contraindications for that would actually be a similar list to what we just did with the IUDs, but it would include patients who have breast cancer or a history of breast cancer that's hormone receptor positive, a history of a DVT or venous thromboembolism, patients who have liver disease, unexplained vaginal bleeding, or undiagnosed vaginal bleeding, pregnancy currently. Those would be the first things that I would think of for contraindications for hormone replacement therapy.
Okay. Tell me about the Women Health Initiative study. What do you know about that?
This was a study that prospectively, I believe, followed a very large number of young women who, or sorry, older women who, postmenopausal women who received hormone therapy, replacement therapy or not, and looked at outcomes in terms of bone health, cardiac health, and cancer risk, as well as menopausal symptoms.
How many arms were there in that study?
I am not sure. I believe more than just two, though. More than just like a placebo and a hormone replacement therapy group, but I cannot recall.
Okay. So which one of those arms had an increased risk of stroke?
I believe the group that received hormone replacement therapy had a slightly increased risk of stroke.
They both received hormone replacement therapy. One of them received estrogen progesterone, and the other received just estrogen.
I believe the group that received the combination.
Okay. So you need to read the Women Health Initiative study. That's a very, very, very hot topic on the oral board exam. They love to ask about hormone replacement therapy. Could even come as case of the day. So that we need to go over. I'll go over it briefly. Tell me what are the other non-hormonal options that you talked about that you would offer the patient?
Other non-hormonal options would include paroxetine, gabapentin, and then there are other sort of supplemental non-medication drugs or acupuncture that could potentially be beneficial but are not studied.
What other medications can you give other than hormone replacement therapy? Like an actual medication?
Gabapentin and paroxetine.
What's the dose of paroxetine?
I believe the dose of paroxetine is 7.5 milligrams daily.
Okay, good. So what about for vaginal atrophy? Are there any medications that you can give for vaginal atrophy alone, not for vasomotor symptoms?
So for vaginal atrophy alone, you could just give a vaginal estrogen cream.
Okay. Anything else?
There are formulations of vaginal estrogen rings, but I think those are sort of the two options that I'm aware of for local hormone therapy.
If you have a patient who has breast cancer, who has postmenopausal symptoms, and is asking you to prescribe her a hormone replacement like cream, vaginal cream, or just a pill, would you do it?
I would counsel them that we don't know the exact systemic uptake, but it's probably very minimal. And so with appropriate counseling and understanding, I think it would be acceptable to use a local estrogen treatment, but I would certainly make sure she understands that any systemic uptake of the estrogen could be problematic if she has estrogen positive breast cancer.
Okay, I'm gonna stop here, okay? Because I want to give you feedback on what we talked about.
Sure.
So indications, contraindications of using hormone replacement therapy. There's a whoosh. Is that from your end? I hear a whoosh.
I just moved my chair. Sorry.
Oh, it's fine. So contraindications would be pregnancy, breast cancer, estrogen-sensitive tumors, undiagnosed vaginal bleeding, severe liver disease, or history of DVT. That will be contraindications to using hormone replacement therapy. The Women Health Initiative study is a randomized controlled trial that was done over 15 years, 160,000 menopausal women aged 50 to 79. The HRT arm has 27,500 women. The study had 4 arms: estrogen progesterone versus placebo, conjugated estrogen versus placebo, calcium and vitamin D versus placebo, and the non-intervention cohort. And so this study showed that women who had estrogen and progesterone versus placebo had increased risk of MI, heart disease, stroke, DVT, breast cancer, but a beneficial decrease in the rate of colon cancer and fractures. And the other arm where there's just conjugated estrogen, that one had the higher rate of stroke of like increased 12 folds, with no difference of myocardial infarctions or cardiac disease, but also increase in DVT and PE, and no benefit on colon cancer, but also decreased the fracture rate. They had some data on Alzheimer's, but they were conflicting, so not really sure how that affects those women. We talked about other treatment of vasomotor symptoms. You mentioned SSRI paroxetine. It is 7.5 milligrams a day. It's the only FDA-approved medicine other than HRT. It's a good substitute for women whom you can't give hormone replacement to, and then clonidine and gabapentin as well, but they're not FDA-approved. As for vaginal atrophy, the vaginal cream, just like you mentioned, but there's also something called ospemifene that is FDA approved for vaginal atrophy. And there's also something else that's also FDA approved. It's a serum. It's called Duave. I think it's mentioned in the practice bulletin. This also helps to treat vasomotor symptoms and prevent osteoporosis. As for the woman who had breast cancer, so I would avoid until I talk to her oncologist. She can get non-estrogen treatment, but I would avoid giving her any hormone replacement therapy unless she talks with her oncologist, because even though it is not a huge amount, but it can still be absorbed systematically. So in the exam, I would say I would refer to the oncologist and not giving to her until the oncologist says it's okay.
Okay, that makes sense. Aside from, this is the first time I've heard like a study be mentioned, because I've otherwise sort of been told to stray away from bringing up anything. And obviously I wouldn't bring up the Women's Health Initiative since I know very
No,
little.
don't bring it up. Don't bring it up unless they ask you.
But what other studies would you say are potentially high yield that we should potentially be aware of? I mean, if it's something that could come up in a case structured, like a structured case on the exam, then certainly if there's other things, then I want to make sure I review those.
Nothing comes to my mind now.
But that's good to know about the women.
I'll think about it and I'll let you know.
Okay, thank you so much.
I'm looking at the questions real fast. I have to go, but I'm looking at the questions. Somebody, Daniela, you wrote some rubbish stuff. I don't know what that is. RKTL 2021, that must be a mistake. And then Jessica asked for the Well Woman exams. There a practice bulletin that has the information? No, there isn't, unfortunately. I had to go gather it by myself online, all that stuff. Where is this? Review physical exam, indicated cerclage. I'm sorry, there was no time for it. Maybe next time. And then Serene said, somebody comes with incidental showing but no bleeding. She has risk factors. Would you sample the lining? Yes, I answered that question. Yes, you would if she has risk factors. Okay, guys, I hope this was beneficial, and you all did a very good job. I have no doubt any of the people that I talked to today would have passed. If this was an oral board exam and you were answering the questions, you would have definitely passed. I think, in my opinion, you did very good. So just keep up the hard work, whatever you're doing, and I wish you guys all the best, and I'm sure I'm going to see you in a webinar next month. Good luck. Good night.
Thank you.
Bye.